Hi, my name is Dr. Jonathan Santoro. I'm an associate professor of neurology and pediatrics at the Children's Hospital Los Angeles and Keck School of Medicine. And today I'll be talking about primary periodic paralysis and really focusing on the diagnosis and treatment of this condition. So when patients come in, I think that this is a really important differentiator. The symptoms of PPP can be difficult to describe, and especially considering that this is happening in younger patients, specifically children and early adolescents, the cognitive and linguistic ability to actually describe exactly what's going on may not be there yet. Weakness can also vary and can be induced by a variety of other factors, including fatigue, stress, and diet, which can often lead us to believe that this is just a resulting phenotype of being tired or stressed out. The astute clinician can establish the pattern, and that's why, as with many neurologists will tell you, a physical exam and history can often be quite telling and predictive of the condition actually being present. So I'll just provide some examples from patients here. These are things that have been actually said in clinic. My leg just won't work for a few minutes and then it gets better. I just feel so tired some days, I just can't get out of bed. It's like I'm narcoleptic, but I'm awake, we had one patient say. Every time I exercise, it just takes me a really long time to recover. And finally, I get jello arms and legs every once in a while, but if I rest, it gets better. And you can tell, I mean, these are not necessarily specific of really one thing or another, but are commonly used non-specific statements that patients may come in with. As such, the patient journey can be pretty variable. Many individuals are seeking primary care physicians or pediatricians as a common starting point, but then the referral process based on what is being described during those initial events determines where they're referred out to. That can include neurologists for the workup of the weakness episodes. It can be psychiatrists under the presumption that this may be psychosomatic, functional, or stress related. Occasionally, nephrologists may be involved if the potassium alterations are actually captured first. Endocrinology can also be consulted and referred to in the setting of the potassium changes and potentially thyroid issues, rehabilitation specialists, cardiologists, and again, many patients will see multiple doctors before actually arriving at the diagnosis. Complicating this is that there's often a lot of anchoring. So when a patient comes in and describes the symptoms, the initial referral is made, and then there is a perseveration on the part of the physician and of the patient to continue working with that initially referred specialty provider under the presumption that that may be the case. And again, this can influence how long it takes to get to the diagnosis, as you usually will want to see the treatment protocols or diagnostic regimens carried out by that initial doctor. But patient and physician knowledge of PPP becomes critical, as this condition, as you've seen here, is very much going to be underdiagnosed given the nebulous symptoms that many individuals will start with and the time that it takes to actually develop a pattern of the disease process.
Indications. ORMALVI is an oral carbonic anhydrase inhibitor, indicated for the treatment of primary hyperkalemic periodic paralysis, primary hypokalemic periodic paralysis, and related variants. Important safety information, contraindications. Hypersensitivity to dichlorphenamide or other sulfonamides, concomitant use of ORMALVI and high-dose aspirin, severe pulmonary disease, limiting compensation to metabolic acidosis caused by ORMALVI, hepatic insufficiency, ORMALVI may aggravate hepatic encephalopathy. Warnings and precautions. Hypersensitivity and other life-threatening reactions. Fatalities associated with the administration of sulfonamides have occurred because of adverse reactions, including Stevens-Johnson syndrome, toxic epidermal necrolysis, fulminant hepatic necrosis, agranulocytosis, aplastic anemia, and other blood dyscrasias. Pulmonary involvement can occur in isolation or as part of a systemic reaction. Discontinue ORMALVI at the first appearance of skin rash or any sign of immune-mediated or other life-threatening adverse reaction. Concomitant use of aspirin or other salicylates. Carbonic anhydrase inhibitors, including ORMALVI, can cause metabolic acidosis, which can increase the risk of salicylate toxicity. Anorexia, tachypnea, lethargy, and coma have been reported with concomitant use of dichlorphenamide and high-dose aspirin. Concomitant use of ORMALVI and high-dose aspirin is contraindicated. Use with caution and carefully monitor patients receiving low-dose aspirin. Hypokalemia. ORMALVI increases potassium excretion and can cause hypokalemia.
The risk of hypokalemia is greater when ORMALVI is used in patients with conditions associated with hypokalemia, e.g., adrenocortical excess, renal tubular acidosis type 1 and 2, and in patients receiving other drugs that may cause hypokalemia, e.g., loop diuretics, thiazide diuretics, laxatives, antifungals, penicillin, and theophylline.
Baseline and periodic measurements of serum potassium during ORMALVI treatment are recommended. If hypokalemia develops or persists, consider reducing the dose or discontinuing ORMALVI and correction of potassium levels. Metabolic acidosis. ORMALVI can cause hyperchloremic non-anion gap metabolic acidosis. Concomitant use of ORMALVI with other drugs that cause metabolic acidosis may increase the severity of acidosis. Concomitant use of ORMALVI in compensated patients with respiratory acidosis, such as in advanced lung diseases, may lead to respiratory decompensation. Baseline and periodic measurements of serum bicarbonate during ORMALVI treatment are recommended. If metabolic acidosis develops or persists, consider reducing the dose or discontinuing ORMALVI. Falls. ORMALVI increases the risk of falls. Risk is greater in the elderly and with higher doses. Consider dose reduction or discontinuation of ORMALVI in patients who experience falls while treated with ORMALVI. Pregnancy and lactation. Based on animal data, ORMALVI may cause fetal harm. Use during pregnancy only if the potential benefit justifies the potential risk to the fetus. It is not known in humans whether dichlorphenamide is excreted in human milk. Exercise caution when administered to a nursing woman. Adverse reactions. The most common adverse reactions seen in clinical trials, incidence greater than or equal to 10% and greater than placebo, include paresthesias, cognitive disorder, dysgeusia, and confusional state. Drug interactions. Aspirin, anorexia, tachypnea, lethargy, and coma have been reported with concomitant use of dichlorphenamide and high-dose aspirin. The concomitant use of ORMALVI and high-dose aspirin is contraindicated. ORMALVI should be used with caution in patients receiving lower doses of aspirin.
For more detailed information, please refer to the full prescribing information at www.ormalvi.com/PI. That's www.ormalvi.com/PI. To report suspected adverse reactions, contact Cycle Pharmaceuticals Limited at 1-857-437-3969 or the FDA at 1-800-FDA-1088 or www.fda.gov/medwatch. That's www.fda.gov/medwatch. Visit www.ormalvi.com. That's www.ormalvi.com for more videos about primary periodic paralysis.